Thanks for taking our time to join us for this webinar. Today's topic is an integral part of any clinician's practice with the advent of genomics in medicine. And the topic of today's discussion would be an indispensable step in the genetic testing process, a webinar on genetic counseling. We have with us Dr. Madhavi Lata. She is a scientist, she is a PhD, and she is a genetic counselor. She will take us through the entire A to Z of genetic counseling, starting from what is genetic counseling to why genetic counseling is needed, where it needs to be focused. So we will start today's webinar. Thank you for accepting to take up this assignment.
Thank you, Dr.
So first and foremost, the basic question: what is genetic counseling, and who is a genetic counselor?
Good evening, everybody. Welcome to the webinar. Okay, so the question of what genetic counseling is. So according to the National Society of Genetic Counselors USA, genetic counseling is a process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contributions to a disease. So to put it in a simpler way, so it's actually a communication process by which patients and their families are informed about the inheritance pattern, genetic and genomic basis of certain clinical disorders, explained in a simple way the complex technical and scientific information, and guided through the testing and management options available. Then coming to who a genetic counselor is. So genetic counselors are specialists who provide personalized help about a person's genetic health, taking into account their family history, medical history, and if necessary, the pregnancy history. So what they actually do is they help a person understand his or her genetic risks, enable them to make an informed decision whether genetic testing is right for them. Then once the results come, explain it to them and what the results actually mean to them as a person or a couple or even to the family. So, and later on even help them to connect to resources, support groups, and also to other patients.
Yeah, genetic counselor has many hats to wear and many roles to play in a clinical setup. So are there any prerequisites for genetic counseling?
Definitely, yes. So the prerequisites for genetic counseling are the detailed family history, accurate diagnosis, understanding the medical aspect of the disorder, like the etiology, its natural history, treatment, prognosis, and burden, and understanding the inheritance pattern so that we can tell about the recurrence risk, and understand the psychosocial impact of the information. So they need to have a training or experience in counseling techniques and understand the concepts of health, disease, and healthcare in the particular appropriate culture. This is very, very important.
So it's like almost like taking a case study the way clinicians do in their clinical practice. So is genetic counseling done in an isolation or is it a multidisciplinary approach?
Genetic counseling is a multidisciplinary approach. So it actually starts off with the primary care physician because he or she is the one who first sees the case and then recognizes that it is a genetic case. And then he or she examines, looks at all the phenotype or the indications that the patient shows, and then maybe refer to a clinical geneticist and a counselor. And depending upon the complexity of the case, it next goes to a psychologist and then maybe a subspecialty clinician and also the rehabilitators.
As I can understand, it's a support system that as a genetic counselor, you will be extending support to the primary clinician. So the patient will always be part of the primary clinician's treatment aspect.
Absolutely.
You are supporting the clinician
Yes.
Yeah. So what happens in a genetic counseling session? Take us through the entire process, what you do, how do you handle the patient, the family members, how do you do the counseling as a whole?
Okay, so basically speaking, the steps in genetic counseling include, like, you have a genetic case, we take a pedigree, there is a process termed as pre-test counseling, and then a genetic test is ordered based on biochemical or chromosomal or molecular techniques, and then there is a post-test counseling. So if we go into a little more detail, the steps involved are like to establish a diagnosis, take the family history, risk assessment and communication, discussion of genetic testing options, and the long-term contact and support. Here, I would like to point out that the family history, risk assessment, and discussion, these three actually come under the pre-test counseling. So let me just go into a little detail of each step. So establishing the diagnosis is the first important step in genetic counseling. This actually a genetic counselor doesn't do if he or she is not a clinician. So this step is actually done by the clinician. So though it is a very crucial step, which involves 3 steps like the history, examination, where all clinical presentations have to be documented, and then go to appropriate investigations. So the next important step in counseling is the family tree, which as geneticists we call it as the ultimate genetic tool. So genetic counseling is actually dependent on accurate, detailed, and relevant information. And this information initially is actually we get very clearly sometimes from a pedigree. So a pedigree helps us in making a diagnosis, determining the risk, and making recommendations. And the beauty of the pedigree chart is it is easily interpretable most of the times. So
tell us what those symbols, the square and the triangle and the circles mean.
Okay,
I don't see a triangle, but the triangle
is there. Yes, it is there. So the pedigree symbols actually I have put up here. So these are some standardized pedigree symbols. So the again there is a paper which I have put up there, so we can refer to the nomenclature, standardized nomenclature. So the symbols the standardized symbols are there for male and female. So if they are slashed, the square and circle are slashed, it means they are diseased. And for consanguineous mating, you have double lines. And then yes, a triangle actually is not there in this particular picture, but a triangle actually means that it represents pregnancy. So based on this pedigree, the kind of inheritance the disorder shows can be actually interpreted. So based on that, we can see that whether inheritance is dominant or recessive. So when we look at the pedigree, immediately we can say such pedigrees that it is an autosomal dominant inheritance. Why? Because there is a vertical transmission pattern. The phenotype appears in every generation. Males and females are equally affected. And if you look at genetically speaking, only one copy of the disease allele is necessary for the individual to express the phenotype. And affected people are heterozygous. And when we say about recurrence risk, the affected parent, it is 50% in every pregnancy. So few examples are like Huntington, tuberous sclerosis, and neurofibromatosis. So the next one is the autosomal recessive inheritance. Again, when you look at the pedigree, you know because there is a horizontal transmission pattern. The trait is characteristically found only in siblings. And again here, just like autosomal dominant, males and females are equally affected. And the rarer the trait, we see that the more likely there is consanguinity. Genetically, 2 copies of the disease alleles are required for the individual to express the phenotype, and that is why they are known as homozygous. And the recurrence risk is actually 25% in every pregnancy. Now, carrier is a...
Yeah, this is where I believe the carrier testing would be highly useful for autosomal.
Yes, so the term carriers actually come in autosomal recessive inheritance. These are heterozygous, they are unaffected, but they definitely carry one variant of the mutant allele. So next is the X-linked recessive inheritance. Here, the hallmarks are, it's never passed from father to son, more males are affected, and all affected males in a family are related only through their mothers, and we call them as hemizygous. And the trait is typically passed from actually the affected grandfather to half of his grandsons. So the typical examples are again DMD, that is Duchenne muscular dystrophy, and hemophilia. So rare like X-linked dominant inheritance, again the same like X-linked recessive, trait is never passed from father to son. But here all daughters of affected male are affected, sons of affected male are normal, we can see these, and males are severely affected. And some of the X-linked dominant inheritance, the trait may be lethal in males. So examples are Fragile X and hypophosphatemic rickets. One other interesting inheritance that we see again as geneticists is the mitochondrial inheritance, where both males and females are affected. The condition is transmitted through the female to all of her offsprings. And if a male has a trait and his spouse doesn't, it means that the offspring will not have a trait. Now we have seen these charts and I have told you the hallmarks of all of these. So sometimes we will not be able to interpret as clearly as I have explained. So some of the factors that actually complicate are whenever there is a new mutation, when there is a germline mutation, when there is delayed age of onset, there is reduced penetrance, and variable expression, pleiotropy. So these are certain factors which actually hinder in for us to see whether what kind of inheritance it shows. Because like in tuberous sclerosis, when there is reduced penetrance, you will not, though it is autosomal dominant, it sometimes it looks like that the person may not be affected, or we will not be able to see correctly that every person in each generation there's a phenotypic expression there. So the third step actually comes to the risk assessment and communication. So once the pedigree is actually constructed and we see the genotypes, we are in a position actually to assess the risk and state the possibilities. So here what we have to do is we have to give as much background as possible, quantify the risk, and then communicate. What happens here is at this time, very, very common misinterpretations can occur when we are telling 1 in 50, 1 in 25, or 1 in 4, 50%, 25%. When I say 1 in 4 occurrence, so, and then there is a difference of how they take it. So most of the time as counselors, we prefer actually to draw a square, put it in a diagram, and then show it to them so that they better understand. It is important to emphasize that the risk applies to each child. So we remember a lady coming there because they had husband was affected with tuberous sclerosis, and she said, I have a normal child and the other child would be affected. So she had already decided that the child would be affected, but no. So this applies to every pregnancy or every child. So we'll have to tell them that chance doesn't have a memory. So it's very, very important to communicate these things. So we'll have to discuss what are the options that they have, provide all information, details of the choices open to them, including all the reproductive and alternative approaches to conception. And at this time, we'll be actually talking to them about the techniques, their limitations and risks. So this is a very important point in pre-test counseling when we say what tests they would be doing, either genetic or like even prenatal testing. So we talk to them about the limitations of the test, even if it is as simple as an ultrasound scan. So it has certain limitations, and then they would be told about the limitations. So these are the things that are discussed in a pre-test counseling. So, and then there is communication. Communication, as we know, is a two-way process. The counselor actually provides information, but as counselors, we also have to be receptive to their fears and aspirations, sometimes those which are expressed and sometimes even not expressed by the consultant. So when I say communication, the individual or couple actually could be extremely upset here. So the information that we present should be clear, empathetic, and given in an appropriate manner. The setting should be agreeable, private, and quiet with ample time for discussion and questions. So as counselors, we see that the session of genetic counseling can last from 1 to 1.5 hours. So, and at this time during the discussion, sometimes they may forget what we have told them, we actually repeat, but in the end, we actually give them a letter summarizing the topics that were discussed. And depending upon the case, there is a follow-up call and appointment to clarify any of the confusing ideas.
As I can understand, genetic counseling is a science by itself, and there are so many processes that is involved. And it's good to know, because most of us believe genetic counseling means only talking, just counseling the patient, but there is absolutely science behind everything that a counselor does. Yeah, that's a good information to share. Are there any principles that are followed during a genetic counseling session?
Yes. So the principles that are followed during a genetic counseling session, which we call as tenets of genetic counseling, are when we are talking, when we are telling them certain things, we are actually non-directive. That is, we don't coerce them to anything. So there's no attempt to direct them along a course of action. And we should be non-judgmental. That is, even if the decision that the couple or the proband reaches that seems ill-advised, but still we don't judge them. We go along with their decision. And whatever they tell us, we keep it as confidential. And the fourth tenet is actually non-maleficence, which all the clinicians do understand, inflicting the least harm possible to reach a beneficial outcome. And at this time, I would like to also say that during counseling, it is very much unwise to answer, like, what would you do if placed in my position? Rather, because this is the question which they ask, because we are putting options in front of them. Each time when this question is asked, we again tell them, consider the consequences of each possible course of action, because it is the consultant actually who actually has to live with the consequence.
So consultant, you mean the proband?
The proband, or he or she might not actually be affected. So that's why we don't call them the proband. It could be like if it is a child when the couple comes, so the couple, they are the consultants.
So what are the indications for genetic counseling? When to see a genetic counselor? Because for every case, one need not have to go to a genetic counselor for genetic counseling. So what kind of patients or what kind of the general population that needs to be counseled?
So the indications for genetic counseling for children, we see that when they come up with congenital anomalies, there are dysmorphic features, there's developmental delay or learning difficulties, such children actually come to the counselings are referred to counseling by the pediatricians. And in adults, it is like after detection, there is for diagnosis, and adults also come for carrier testing, as we discussed during the autosomal recessive inheritance. And for predictive testing where there is anticipation, like in Huntington's, where there is family history and they want to know if they are actually carrying it again. And there's a family history, like for example in cancer. Then even a couple, when they're planning a pregnancy, then also they come for counseling, for carrier testing, even if they don't have a family history sometimes, to see, because we all are carriers of a minimum of 2. I think Dr. Sheetal had spoken in the previous webinar on carrier screening, and then
with the change of demographic, so everybody are looking for having 2 healthy babies.
So they do come for carrier for testing, and then they come for counseling. And if there is a family history, definitely yes. And otherwise, couples with recurrent pregnancy losses and infertility, and if they had early neonatal deaths. And during pregnancy, yes, if there is advanced maternal age and there is a known genetic disorder or abnormality which is detected on screening, they are actually referred for genetic counseling. So specifically in oncological indications are considered, I've listed out few oncology specific cancers. So these should be considered only if there is a compelling family history, there is a young age of onset, and there are bilateral lesions and or family clustering of the related tumors.
So genetic counseling is becoming more and more an integral part of the clinical practice with the advancement of genetic testing as a whole. So how and why is genetic counseling becoming, in your opinion, an integrated part of healthcare services? A couple of reasons being, this is the genomics era, so more and more people are getting into genetic testing. As a genetic counselor, what is your perspective?
So when we say it is becoming an integrated part of healthcare services, genetic testing started. So these test results actually provide a sense of relief from uncertainty. These technologies were not there earlier. So we didn't know, I mean, the clinicians didn't know that, okay, they knew it was a genetic disorder, but they were not able to do certain tests. But now when you do a test, it provides them the relief. And then it helps people make certain informed decisions of what to do next. And new information about causative genes for genetic disorders and birth defects is actually coming into light. So these diseases can be diagnosed and managed well with relevant tests and then interpreting them. So sometimes these tests also, what they do is they may explain a child's symptoms sooner than actually when we wait, because many of them are actually progressive. So in progressive, if you know earlier, so sometimes the clinician can intervene in between and then see that what can be done about it. And new genes are also being found for common predisposing factors like for cardiovascular and diabetes and cancers, see which are the genes which are predisposing. And then this actually helps to inform the patients about new treatments based on the understanding of the genetic basis of disease. This is one part. The other thing is the genome analysis techniques also have changed over time. So there was only karyotype, then came microarray, and then came NGS. And depending upon the scale of variation of the human genome, we have different tests. We all know that there is not one single test that can answer all the questions. So depending upon the disorder and what we need to find, the different kind of tests are actually done, and then the technique is actually suggested.
So it becomes all the more clear that in a clinical setup, especially offering catering to genetic diseases, the importance of genetic counseling is paramount. So the basic question is, in such a setup, just to clarify our audience, why work with a genetic counselor? Explain to us why it has become imperative in this changing scenario to have a genetic counselor on board, especially for catering to genetic diseases.
Yeah, so I have taken two quotes from clinicians which was put up on NSGC. So the clinicians say that working with a genetic counselor can fill in the gaps. They make sure that the patient receives appropriate discussion about testing and implications of the testing, and they say that they know about the next steps. They're reassured actually, and they understand better the test results. So what we feel is working with a genetic counselor increases your patient satisfaction so that they can make informed decisions, which actually saves time and money. And as a counselor, we can provide you with crucial support by devoting our time to the patient care and education. Right now, we see the doctor-patient ratio is very, it's not good. So where we can actually support them, as I told you earlier, there is the time for genetic counseling is actually almost 1.5, almost 1 hour. It starts with 1 hour. So it's like this is the time which we can provide to the clinician. And also when there are results, like when there are variants of uncertain significance. So because we are having training in molecular biology or genetics, we can reduce a little confusion when we are interpreting these kinds of genetic test results.
Okay, what are the clinical principles guiding the genetic counselor?
Okay, so
there has to be some limitation, right? You cannot actually become a clinician and be part.
Yes, exactly. So just like in every field, we also have certain ethical principles which guide us. So the ethical, legal and social issues in genetic counseling are autonomy, that the patient's right to information and his or her right to make his or her own decisions. And next is beneficence, like taking action to help benefit others and prevent harm. The third one is non-maleficence, duty to minimize or prevent the infliction of harm. And the last one is justice, that is services to be distributed fairly. So we have certain guidelines laid out. ICMR has its ethical guidelines, the NSGC has its guidelines, and even the NCCN guidelines also. So we follow all of them, and then we do the counseling. So the ethical issues sometimes we face is like during sex determination, pre-symptomatic testing in children, whether it should be done. So we say that it shouldn't be done at all, only after 18. But there are exceptions. And then the duty to warn third parties when, why, where it should be done, should not be done. What about unexpected findings? And there is use of genetic information for discrimination. Actually, GINA is an act in the US only US has it. No other country in the world has. But then it's a very good thing that they have started. So when we are actually counseling, we keep certain things in mind, like from where we are. These are certain guidelines which are given all over. So when we talk about ethics, I say that the Western ethics are about rights and principles, and the Asian ethics are about caring and relationship. So this is what was told to me by the counselors from our country. So we actually read all the principles and rights, but when we come to our country, we know that it is different. So the picture I have put up here in ethical issues, this is actually from MDCRC, where they follow something called group counseling for Duchenne muscular dystrophy patients and their families, which actually wouldn't be to say ethical in the Western guideline principles or rights, because they say that my autonomy or privacy, but it has been working very well for him. So we know how our culture is and how our society works. So accordingly, we are in the framework of these rules and regulations, and still see that what is the benefit, how the patient benefits maximum by doing this.
So in a way, you're actually customizing as per the need.
Yes, for our society, definitely, yes. So when we talk about ethics, definitely there are certain questions. There are usually in prenatal, it comes like people ask, is it important to detect prenatally the genetic disorders? So they talk about, yes, we have our reproductive rights. You are actually preventing the suffering, improving the quality of life. And sometimes you give the family time to prepare both financially and emotionally to have maybe a physically or intellectually challenged child. But there are also the other group which say that if you ask them, is it inappropriate, they say yes. And then they ask, who is actually qualified to define the quality of life? Everyone has the right to exist, and this actually prenatal testing perpetuates negative attitude, making there would be a general lack of knowledge about disability. So these such questions are asked. So I personally feel that the genetic counselor is a collaborator between genetic information and technology, and the lives of people who are affected by this technology.
So you mean to say there is definitely benefit with the advancement of genetic information technology, and the genetic counselor acts as a bridge so as to dispense the clear-cut, information, the right information.
Right information. So that they make informed decisions. Okay. So we call it as informed decisions. So what we do is, like, there is a balance between the science with attention to the psychosocial concerns. Yeah. So we keep in mind both principles and practice, but we are also well versed with the socio-cultural norms, beliefs, and practices. So what we say is the first step towards change is actually awareness. So let them be aware of, like, there is genetic testing, and then let them make a decision of whether to go for testing or not. And then the second step would come as to the acceptance.
Okay, so that's an important saying or quote from one famous person should be, because the quote makes so much of sense. Creating awareness about the new technology, its limitations, how to make use of the technology for one's own benefit. And yes, there are some things, there is limitation in everything that we do, and accepting the limitation and moving forward with the difficulties of life is, yeah. So are there any case studies, or are there any examples that you can actually share with us so as to make this particular point about genetic counseling as a whole very clear?
Okay, so I have put up 2 or 3 cases. So the first case which I would want to share is of a 43-year-old male referred for optic atrophy. The clinician called me, and then there was a family history present on the mother's side. And I was also told that there was some tremors in the hand. So, and then the doctor told me that it looks like a mitochondrial inheritance. So I said, okay. Then what we spoke to the proband, and then we got the family history. Now, as soon as we look at the pedigree, as I discussed earlier, so when you look at the family history, you would directly see that there is male to female transmission, which in mitochondrial inheritance couldn't happen. So that is absolutely ruled out. And then when we spoke to them, we saw, we got another detail that we got was age of onset was 10 years. And then he told me one more point, that his brother too had tremors. So with this, what we did was we went ahead and then we did sequencing, and then we got a pathogenic variant was identified, which actually causes optic atrophy OPA1 gene, which is actually the autosomal dominant form, which showed the inheritance as being shown there. Now, you people would be thinking, like, what about the tremors in his hands? Here, I would want to say that why I took again this case is this particular person actually belonged to the Agarwal community. Yeah. So when he said tremors in hands, it could be 2 things. That yes, that this person did have maybe it's because of OPA itself, because there are certain neurological which are actually presented. But then it could also be that because they belong to a certain community and his brother is not showing the symptoms, maybe it is something completely different. So we asked them to go for a complete neurology. So he went to a neurologist, and the neurologist said that it looks like ataxia. So he said check for ACA12. So we have not yet got back, but I put this case because this is how a pedigree helps, and also knowing that when a particular person belongs to a certain community, there are certain disorders which are specifically shown in certain communities. So
founder mutation.
Yeah, so what we have is we should have certain knowledge in what happens in our country, in our communities. So the next case which I have put up, because the next 2 cases actually, because these came to me from the clinicians immediately. It was like not a slow reference, but the fetal medicine specialist called me, and then she said, I need you to come to me immediately to my OP. I have a lady who's like crying that she wants to do a medical termination immediately. So it was like, okay, it was also a psychosocial counseling together. So one of the problem here was her older child was affected, I mean, diagnosed with osteogenesis imperfecta. As soon as she realized she was pregnant, she came immediately to the gynecologist telling that she wanted to terminate. So then she came because she had come with her parents, and then we spoke to her, and then immediately both the doctor and we spoke. There were counseling done, and when we took the family history, we saw that they were consanguineously married. So then we said testing is available, and there was enough time for her actually to test her affected son, and then see that whether her child is affected or not. There is no need to go for termination immediately because she has this choice right now of genetic testing. Okay, so then they agreed for it immediately, and
more
then
than anything else, they have the right to have a healthy child.
Exactly. Yes. So when this choice was given to them, they took up the child was tested, and then we found a homozygous mutation. Then and then immediately, so we got the result when she was around 12, 13 weeks pregnant, and again the fetal medicine specialist waited till so we did an amniocentesis, and then we came to know that the sibling, the fetus, actually is heterozygous. So we were happy actually that we could help her. And personally, we feel that one unnecessary medical termination was prevented. So
and she continued the pregnancy.
Yes, she continued, and she has a healthy child. So the third case, again, the last case which I'm sharing with you people is one which again I got from a pediatrician, where the boy had DCM, was diagnosed of dilated cardiomyopathy, and then having a strong family history. She said the boy might not survive another day, but she said, because she knew me, she said, Madhvi, it is very important that we take the sample. The woman is only 34 years old. So they might not agree, but I need you to talk to them and counsel them. So these are sometimes, because even they don't listen to the doctors sometimes, so they call me, and because we take them to a different setting and explain certain things to them. So when I spoke, again, actually here, usually when the children are concerned, we prefer both the couple being there, but here it's like, because the boy was not well, the father agreed to come. Then when I took the pedigree, we came to know that they had lost two children actually. The first child passed away at 28 days. They had thought that it was SCID. The second child passed away at 8 months. And then when this happened, the child was actually sent for autopsy, and at that time is what DCM was detected. But then they had done a karyotyping only. So because the karyotype was normal, they went ahead with the third pregnancy. So this was the time when I counseled them, and I told that karyotyping is a test, definitely it's a genetic test. And they were like, he said, we are normal, we have a normal karyotype. So then I said, no, this is a different kind of disorder where a different change happens in your genome. So this is a single gene mutation where a karyotype doesn't answer your question. You need to do a sequencing. So then, and this time the father was like, no, ma'am, now we are not going to have any more children. We are going to stop. It is enough. We have seen enough.
Yeah, so, any parent
undergoing this
for 3 consecutive
deaths
of the baby.
Yes, that they have seen, yes. So, but at that time, what happens is when we talk to these parents, we tell them that pregnancy is not something that is always exactly planned. So in case like there is because this is consanguineous marriage also. So again, in case they get pregnant, if they come back to the pediatrician, that is what the pediatrician was telling. If they come back again to me, I would not be able to help them in any way. So it is very important, even if they don't want to do the test. Why I shared this information was, when we counsel them, we tell them that even if they don't go for genetic testing, it is okay. It is very important for them to preserve the sample of their child, because the DNA can be isolated and stored. So that time of counseling and telling the parents that this choice is available. Even 4 or 5 years back, this choice was not available to any parent. But right now, if the couple decides, if they want, so it's not to tell them to store the sample, but the counseling is done to tell them that you have this choice. If you want, you can take it and keep. If you don't want, yes. So it is like, again, giving them the choice and the right to make a decision in their life. So yes, we got a call after almost 2 days. The boy passed away after that. But after 2 days, he called me and then he said, I spoke to my wife, and then initially it was a no, and later they decided that they would want to save. So they have not gone for testing, but then yes, they did save the sample of their son. And then he called actually after a few months, and then he said, do we need to test ourselves? So then, yes, we had taken this test, and we have actually taken to us as in MedGenome, we have taken it under familial genetic disease study.
Yeah, thanks for sharing so much of information as well. The case study, genetic counselor, I believe, has to take a step back and not get personally involved and become emotional. They have to be very reasonable, and they have to follow all those ethical principles so as to be non-directive, the way you rightly put it across, because we are here to help as a genetic counselor is what you will be telling the families and the affected children. And yeah, that's really enormous information packed in 45 minutes of your presentation. Thank you so much. And as you are aware, genome clinical genomics actually has 3 divisions: Claria for reproductive genetics, Actia for medical genetics, and Prima for cancer genetics. As of now, we are offering genetic counseling for Claria, that is for reproductive genetics. Pretty soon, MedGenome is planning to extend the genetic counseling services to its Actia division as well as Prima division. And thank you for your patient listening and your participation. We now go ahead and answer some of the queries raised by the participants. If there are any, yes, there are, as I can see, there are a couple of questions. So we will also be joined by Dr. Sheetal Sharda, if as an expert. Dr. Sheetal Sharda, as you're aware, in the last webinar, ma'am actually presented on the career testing. And as a geneticist, we will also be posing some of the questions to ma'am as well. So, are there any conventional schematics to present information is one of the questions that's being raised.
Conventional schematics.
Meaning as a flow chart with figures, and this is
definitely yes. So when we are actually counseling, we do keep these pictures because it is very easy for them to understand with pictures. So we every time there's an inheritance pattern, we actually draw and show them. We have pictures with us. There's a file sometimes that we have, and then they would want to actually see when you show them that there are 2 copies. When they look at the chromosome structure, DNA structure, definitely people are interested, and then they get an idea of the language of DNA. And initially, I thought that maybe when you talk about ATGC, people wouldn't understand, but then definitely they do understand the language of DNA when you tell them. Most of the time, if I have to tell the person who asked the question, I'll have to say that the pictures which I share with them have always gone off. The consultants who come to me, they ask, ma'am, can I have this paper? And then they go off with the so it is good to counsel with the pictures.
Yeah, actually. And also there won't be any difficulty of language barrier when you show pictures.
Yes.
That would be another additional benefit as such. Yeah. So when it comes to, is it important to do the genetic counseling in their mother tongue, or just because we happen to see an educated couple, as a genetic counselor, we would prefer English or Hindi?
I have observed that when we speak in their own native tongue, people are more open, and there is a sudden buildup of rapport. So usually the pedigree, according to, we say that when we are actually asking their family history, that is also a time when we are building up a rapport with the proband or the consultants. I have also observed that the language, when we speak to them in their native language, people open up and they speak up, and there are lots of things that are shared. So as much as possible, yes, talking to in their native tongue is far better.
So, in your opinion, is the pre-test counseling important or post-test counseling more important? And that's one question asked by one of the.
Okay, both pre-test and post-test are important. But if you say which is the most important, pre-test definitely yes, because we don't know if we wouldn't think of post-test, because we won't even know. As a counselor, we are not doing a counseling that they go for testing. So during the pre-test is the when we tell them about all the options available and what are all the risks. So even if they don't go for testing, they are actually informed about what is already present and what they have taken or what they have not taken by not going to the test or by taking up the test.
So in a way, you're honoring their right to have the right information.
Yes, exactly.
So another question that I actually come across more often is people after going for genetic counseling, after getting counseled for genetic test doesn't come at a very nominal price. It's quite pricey as of now with the present technology, but it is said with the advancement of technology, the sequencing cost is going to further come down, and it is going to be made affordable for the masses in general. So looking into the present scenario, if when you write in the pre-test counseling, when you write the pedigree, yes, there is a definite familial genetic disorder that you can actually appreciate looking into the pedigree chart, but the report comes as unknown significance. So how do you manage? Because one of the slides you actually explained, you actually look into the cost benefit analysis of the family as well. But family has done everything the clinician actually asked for, and they get a report, and they come to the genetic counselor. This is the real case scenario I believe we will be facing in most of your genetic counseling sessions. How do you handle such?
So it's like when genetic test reports are given, these are actually based on the clinical indications that are given by the clinician. So according to the clinical indications, so are there any variants that can be found? If yes, they would come under pathogenic or likely pathogenic. If no, they would go under variants of unknown significance. Now, even if the clinical indications are right, absolutely, sometimes we can, I think Dr. Sheetal would be far more, because she's looking into these details of the testing and different variants, right?
So you meant to say, I will pose the question in a slightly different format for a clinician and a geneticist like Dr. Sheetal Shatra. So, ma'am, when you get a test report of variations of unknown significance, patient has actually undergone, all the clinicians actually ask them to underwent the pre-test genetic counseling. They underwent the test and they get a report of VUS. So, what is the scenario for from clinician's perspective, and what will be the further thing that a patient with a report of variations of unknown significance has to do, looking into? But the pedigree chart shows there's definite familial disorder.
Variant of unknown significance is sort of a very known term now, because almost and it is only for NGS or next generation sequencing which we use this term as, and it is just that we have found a variant, but we don't have enough evidence to call it as pathogenic or likely pathogenic. Even if it is matching the clinical phenotype, sometimes it is a new variant. So if it is a new variant and it has not been reported in literature, and the softwares which predict the protein change which is going to occur due to that variant is not very strong enough to tell us, then probably we have to put it as VOS. And almost like 30-40% of the reports are going out as VOS because we don't have enough literature to help us. The pathogenic and likely pathogenic are that there are functional proofs, or there are enough case studies or enough families in the world which have the same variant and causing the same phenotype. And so we are very confident in giving that variant. So variant of unknown significant is only for NGS reports. So we need to know the limitations of NGS report before we ignore that US. So it could either go towards likely pathogenic, or it could go towards benign or likely benign based on the additional finding. Sometimes the phenotype which is given to the lab or to the team is not enough to give a very strong genotype-phenotype correlation. Sometimes that a few more additional findings can help us include that as likely pathogenic. Sometimes it is that we just need to do a segregation study. Segregation study is that it is a new mutation or a new variant. So whether it is coming from the parents or it is absent in the parents, that will give more weightage to that variant. So in a case of autosomal dominant condition, if the parents are asymptomatic and neither of them have that variant becomes a de novo sporadic new mutation, and that will signify, okay, this is a variant which was not there in the parents, but it is matching the clinical phenotype, so it could be significant. But if either of the parent has the same variant which was found in the proband, then it decreases the significance of that variant because parents are asymptomatic. Unfortunately, in autosomal dominant condition, the exceptions are decreased penetrance, variable phenotype, variable age of onset. There are multiple things, and sometimes even for that VOS, even if the parent is having the variant, we still cannot ignore that variant, but it will still be a VOS because we don't have backup. So we need to again go back to the parents, ask them again whether they have a milder phenotype. Sometimes the same disorder has an early onset also, but in the parent, it may be a delayed onset. Sometimes there are multiple features in that same phenotype. So the father may not be having something severe, just a single 1 or 2 capillary spot, or the mother may be having some hearing problem, but it is so mild that she may not even go to a clinician to get herself checked. So in that way, we tell them that please reevaluate the parents. Possibly they are mildly affected, and in that way we can then give a significance. But we all know that VOS is not only for NGS, even for small metabolic disorders, we never get a 100% report. It is sometimes unequivocal, or it is so much in the borderline area that we cannot give a yes or a no. In the same way, for NGS reports also is the same. Sometimes we have to revise our diagnosis. Sometimes maybe we have sent the wrong test. It is a triple repeat disorder. It will not be picked up in a NGS. So that will come as a non-report in spite of having a very strong relation. So sometimes these few limitations which are there should be understood by the clinicians first before counseling the parents or the family. That this cannot be ignored, but we need to further test you or other family members.
So to our general audience, genetics is not a linear science.
No, genetics is never 1 + 1 is never 2 in genetics. That I tell it to everybody, that it's not so easy. We have to understand the pros, the cons, the limitations, the advantages, disadvantages, and that's why what Marvi said, pre-test counseling. That is much more important because we have to tell. What everybody thinks is that if we send one test, it is like 100% and a result has to come, and then that will be the end. But they have to be given that, okay, the chances of getting a positive answer in your case is approximately 75 to 80%. Failure rate of 20% is still there. Even like Dr. I.C. Verma himself, I always remember his quote, he says that genetics is one branch in which 50% failure rate is acceptable. Failure rate of 50%. But now we are going for a better state with all the tests, but still we are not 100% for genetic.
So it becomes all the more important for the patients and the labs and the clinicians to follow with those mutations with the new publications, and whether they can group those VOS into pathological.
Yes, definitely. Every lab report, if you check the disclaimers, they will write that you come back to the lab. If it is an old report, even if it is just 6 months old, before basing your future management prognosis or even prenatal diagnosis on that report, we always advise that please reanalyze the sample. Within the 6 months, you may get a different thing in the patient, which has, like today itself, we were reporting a variant which is not even there in our homing. But we have got 2 papers which are saying that this variant is associated with this disorder. So even if it is associated and the patient is having that variant, the clinician needs to know. So even if we don't put it as a pathogenic, likely pathogenic, we even don't know what basis it is, we have to inform the clinician, see, we have found this variant, but it needs to be validated. So, later on, if after 6 months or even after 2 months, they come back with a more stronger literature, we can put it as well. So they have to get back to the lab that we want to reanalyze the data.
Yeah, so it's a continuous process, continuous discovery.
Especially if they want to do prenatal, I would request everybody, again, confirm, reconfirm. Please do not do a prenatal based on a BUS report. We have to confirm the significance before we do.
So let me check for the final time. Are there any further questions? If not, we can actually all. There are a couple of questions. How to ensure the subject is aware of consequences before going for genetic testing? This is from Puneet. Yeah.
How to ensure the subject is aware of the consequences? Yes, that is the genetic counselor.
That is what is actually told during the pre-test counseling. So if you are sending the person for depending upon like Dr. Sheetal was telling, if it is NGS, we tell them that there could be variants of uncertain significance that come up. And then if it is like, if they're going for a prenatal testing, for example, and then we tell them what is the limitation of certain tests. It is not 100% or what it can detect. So if you're even for a simple test like karyotype, so karyotype tells only about the numerical and structural abnormalities, but again, it would not be able to detect certain microdeletions. So these are the things that we say depending upon the kind of test that is suggested to them and what would be its limitations.
I would like to add to that consequences, sometimes you have put a very wide word, but consequences of prenatal testing, if I take for that, so when we explain to them that we are going to do prenatal testing, then we have also to tell them that if it comes positive, you have to be ready with a decision whether you need to terminate or not. Some families or some religions or ethics, they are not for termination, right? So in those cases, giving them the option that, okay, you need not do a prenatal, because we tell them that there is no treatment. What they expect is if we do prenatal, fit treatment ho jayega na. So the next question is that in utero treatment of the fetus. So we have to tell them that this prenatal testing is for a disease which is not treatable. It may be lethal. It may have many abnormalities later on. So you may have to terminate in case the fetus is affected. So if you are ready for that, we can go through all the steps. Or if you want to stop, we can stop it. So they need not even do a prenatal test.
That's like taking informed consent,
but
making process.
But as a counselor here, I would say that whether to go for termination or not, again, is their choice. Maybe they would want to. Maybe they want to be prepared.
That the consequences.
Those
Their
consequences
right
are
to
discussed.
information will be respected.
Yes.
And accordingly, they need to take the call looking into the end objective in mind.
Yes, definitely. Because for them, if a fetus is affected, the usual thing is abort it, terminate it. This is what they keep hearing. But they have to be given options that termination is not the only answer. There are other options available.
Some of the metabolic disorders one can manage even with the
even for like condition like hemophilia. We did not do a prenatal, but some are so adamant that we want to do it. Okay, do it. But then we have to give them the option that okay, it can be treatable, managed, newborn period, early testing.
Some of the parents, well-educated parents, might want to know and start managing their baby the day and the baby is born. So,
don't give milk or starvation. Right? So for that reason, if they wish to know, that will be only for families in which they have seen a child. But now prenatal is being done for any reason, like okay, let's do it also.
Some family wants to have only one baby and they absolutely want that baby to be adopted. So another question is, do you think it is feasible for the general population of our country to afford a genetic counselor service? If I may answer this, most of the genetic counseling in many of the hospitals is almost offered as a free service, Having said that, this is an important science to be adopted with the way and the genetic testing and molecular diagnostics is taking deeper roots in the clinical practice. And I think from institutional perspective, bigger institutes have to make facility for the genetic counseling service so as to afford.
Especially when clinical genetists are not so many, and even the clinicians don't have enough time. Genetic counselors can be incorporated into the routine.
And I see in most of the IVF clinics there is a genetic counselor because there is definitely a need for them to know about in vitro fertilization. That way, there has been major acceptability in few of such kind of setups, but in general, the need of the hour is to provide genetic counseling services. Couple of more questions. How to ensure the subject is aware of consequences before What are the complexities of managing the patient record who came for counseling? That is one part, the privacy of the.
So it depends, like working in a hospital, so it is actually entered into the medical, the electronic medical record. So where it is like only the clinician to whom the patient has actually, or the clinician whom the patient has, the clinician who has referred the patient to us. So in their records, it would be there. Plus, we actually also maintain our own records of all the genetic counseling sessions, and then what was spoken, and then any of the follow-ups that are done, and what kind of questions were asked. So yes, the complexities, if I have to tell you as a counselor in India, because we don't have a very, very strict rules and regulations of what to be done and what ought not to be done. So right now, we are taking care that we do everything according to certain guidelines, so that everything is like at least we maintain the records properly, so that tomorrow if something comes back and then we need to check out on a few things, so all the information is actually available. But the Board of Genetic Counselors in India has actually started trying to make certain rules and regulations, but it has not completely come into action.
So that answers the queries raised in the Q&A chat room of Zoom webinar. And I just want to add one important point here. As you are aware, MedGenome through Claria actually offers a free genetic counseling for NAPT, pre-implantation genetic screening, and carrier screening tests. So whoever is interested can write to us. There is a toll-free number, and then the email diagnostics@medgenome.com, and our website medgenomeclaria.com. Thank you for your patient listening, and thank you for your participation. Thank you for your time. We will again come out with one more announcement of the next webinar. Meet you again soon in a couple of weeks from now. Thank you, Ananda.
Thank you.